we are nursing students from Mississippi University for Women. We are currently in the baccalaureate program there, and we're going to be speaking to you all today about COPD. I'm Rose Anthony. Kim Thompson is going to be discussing the risk factors of COPD, the pathophysiology, and the common signs and symptoms. And Monica Thibodeau, she's going to actually start in the beginning with the history and the definition and incidence of COPD. And then Wendy Fields is going to be speaking to ethical factors, the impact of the disease, and the plan of care. I'm going to be telling you all about the common signs and symptoms of COPD, the diagnosis and prognosis.
Our objectives for today are 90% of the audience will be able to define chronic obstructive pulmonary disease, 100% of the audience will be able to list 2 signs and symptoms of COPD, 85% of the audience will be able to list a tool used to diagnose COPD, and 100% of our audience will be able to discuss the primary ethical issue regarding COPD. First off, with our history, the earliest references to emphysema came from the physicians O'Neill, Morgagnis, and Bali. Back in those times, smoking was rare, so they proved that it was mostly a familial predisposition or environmental provoking factors. The first spirometer was invented by John Hutchinson in 1846. It's now used as a key diagnosis and management of COPD. Took over 100 years before it was actually completed and able to be used for diagnosis. Ronald Christie is known as the great teacher of emphysema. He proved that it's really up to the history and the physical examination for the diagnosis of COPD. The first comprehensive textbook on emphysema was written by Barak and Bickerman in 1956 and was called Pulmonary Emphysema. Had 17 leading clinicians and clinical scientists who contributed to the text. The definition of COPD from 2014 of the Global Initiative for Chronic Obstructive Lung Disease states that it's characterized by persistent airflow limitation that is usually progressive and associated with enhanced chronic inflammatory response in the airways and the lung to noxious particles or gases. No longer includes chronic bronchitis and emphysema. The incidence of COPD. It's the 3rd leading cause of death in the United States, 4th leading cause of death worldwide. An estimated 14 million people in the United States are diagnosed with COPD, and there's an estimated 14 million people who are thought to be undiagnosed. COPD accounts for 16 million outpatient office visits annually, 500,000 hospitalizations annually, 120,000 deaths annually, and an estimated $50 billion in annual direct and indirect healthcare costs. It's more prevalent in the Midwest and the southeastern states. It's also more prevalent in women. Statistics for women dying from COPD have been greater than men since 1999, and women are 2 times as likely to be diagnosed with chronic bronchitis. Nearly 80% of the deaths from COPD are non-Hispanic whites. For us in Mississippi, according to the 2011 statistics, 181,617 of the population were diagnosed with COPD. 7.6% were male and 8.8% were female.
Risk factors include smoking. 80 to 90% of COPD in the U.S. is related to smoking. Other risk factors include occupational or respiratory irritants such as secondhand smoke, air pollution, coal dust, cadmium, silica, and dust. Additional risk factors are age greater than or equal to 50 years, childhood respiratory infections, asthma, history of tuberculosis, poor nutrition, alpha-1 antitrypsin deficiency, alcohol consumption, intrauterine growth restriction. COPD exacerbation risk factors include infections, both viral and bacterial, heart failure, pneumonia, pulmonary embolism, inhalation of irritants, non-adherence to prescribed inhalation medications. The pathophysiology. This chart shows where tobacco smoke and air pollution can cause inflammation of the airway, which can lead to irritation and inflammation of the bronchial and breakdown of elastin and lung tissue, which all leads to airway obstruction and air trapping. Toxins irritate the air sacs and swelling occurs. Cycles of respiratory injury and attempted repair causes airway restriction. Alveoli are destroyed and elastin is lost. Chronic inflammation causes excess mucus production and accumulation. Chronic bronchitis develops. The ciliary function is impaired and cannot clear tenacious mucus. Airways are constricted and/or obstructed. Continued inflammation causes alveoli destruction, which is loss of elastic recoil. Large air pockets form. Emphysema can develop and cause expiration becomes difficult, hyperexpansion of chest, hypoventilation, and hypercapnia.
Okay, the signs and symptoms of COPD. COPD initial stages would include dyspnea, fatigue, cough, increased sputum production, and weight loss. And then the advanced stages of COPD, you typically see edema, cyanosis, plethora, and labored breathing. Other signs and symptoms of COPD, most patients that have COPD exhibit features of both chronic bronchitis and emphysema. Some patients present with a pure phenotype characterized predominantly by chronic bronchitis or emphysema. Signs and symptoms of the bronchitis include a productive cough, history of smoking, prolonged expiration, cyanosis, hypoxemia, chronic hypoventilation, polycythemia, peripheral edema, pulmonary hypertension, and cor pulmonale. The signs and symptoms of the emphysema include dyspnea, wheezing, a history of smoking. They have the barrel chest appearance, prolonged expiration, pursed lip breathing is a technique used, and loss of weight and muscle mass. Here's a picture of the chronic bronchitis patient is on your left, and on the right is the typical appearance of an emphysema patient. There again on the left, you see that he does have some peripheral edema. He appears very fatigued and weak. The cor pulmonale, the right-sided heart failure, you tend to see the edema in the lower extremities as he has. And then the emphysema patient, you can see that he is using his accessory muscles and really struggling to get that air out. Diagnosis and prognosis of COPD. Physical assessment of the patient, that would include, of course, auscultation of the lungs, capacity for independence with ADLs, and a cacadic appearance. Also, pulse oximeter readings, they measure hypoxemia, arterial blood gases, typically the ABGs, they reveal that a patient does have some acidotic state going on, and that depends on the severity of the hypoxemia as to how acidic their blood gas is. Also, a complete CBC, it may show an elevated hematocrit. Other measures used to diagnose COPD, the spirometry is used to measure their flow into and out of the lungs. The forced vital capacity is the FVC, and those levels are monitored. So when the airflow is obstructed, the FEV1 is substantially lower than the FVC. The ration measures below the normal of 70 to 80%. And the FEV1, that's the forced vital capacity, expired forced vital capacity, it correlates with the severity of the disease. The lower the score, the more severe the disease is. There's another test, it's the COPD assessment test, known as the CAT test. The patient completes a questionnaire that assesses the impact of the disease on the patient's health status. Usually, if they score from 0 to 40, below 10 represents a low impact, and scores above 20 indicate a high level of impact for the disease prognosis. A 2-point or greater change in score is clinically significant. The Bodie Index is a grading system designed to predict the death risk from COPD. Based on the 4 factors for which it was named, it's the BMI, O's for obstruction, D for